Hi class, welcome back for part 2 of chapter 8, Adult Disorders. We're still going to be referencing those 6 behavioral symptoms, so if you need to retrieve that document, that would be very helpful before we start. What we're going to do is go through the different types of aphasia syndromes and their defining characteristics. So this is where those behavioral symptoms will come into the conversation. In your book, this is on table 8.2. Remember, aphasia meaning a language disturbance after the time that language has been established. So it's some injury or insult to the neurological system after language has been acquired. It is always due to a disturbance in the language centers of the brain in the left hemisphere of the brain, or the language dominant hemisphere. So the first type of aphasia, this will be familiar too because we talked about it way back up at the beginning of the semester, is Broca's aphasia. So the damage, is in Broca's area of the brain. It's in the frontal lobe, left hemisphere. It produces a non-fluent, expressive motor aphasia. So if you were looking at those 6 behavioral symptoms, you could put Broca's underneath non-fluence and motor involvement, okay? It's going to have, because of that, we know there's going to be labored telegraphic speech, decreased phrase length. The melody of speech is going to be adversely affected. Speech may be agrammatical, which is what gives it that telegraphic quality. So omission of those small function words. Missing or inaccurate tense markers is part of the issue with grammar. Folks with Broca's aphasia have pretty intact self-monitoring because they understand. So they hear themselves. They know it doesn't sound right. They have awareness of their difficulties. They have mild to moderate comprehension difficulties. It's not the overriding symptom of Broca's aphasia. They have highly variable repetition abilities. So you see I'm going through those behavioral characteristics. We've talked about fluency. We've talked about motor issues, comprehension issues, now on to repetition. Highly variable. Sometimes folks with Broca's aphasia can repeat well and sometimes they can't. They have mild to severe anomias, but remember it's going to be typically phonemic paraphasias, those relating to sound. Their reading and writing difficulties are going to parallel their speech difficulties. So reading aloud will be laborious. It will be very difficult for them. Writing will be very effortful. They may even exhibit, it's called macrographia, where they're very oversized writing. Okay, so those are kind of the symptom mix of a Broca's aphasia. The next one is transcortical motor aphasia. Damage is again in the frontal lobe, but it is in the superior anterior portion, so the up high and way toward the front. It is going to also result in a non-fluent, expressive motor aphasia, very similar to Broca's aphasia, except their repetition ability is much better than their spontaneous speech. So this is our first time where we have to look at all of those behavioral symptoms. We have to look at repetition and how it compares to the other presenting symptoms. So spontaneous speech is going to sound very much like a Broca's aphasia with all of those areas of weakness, but the person with transcortical motor aphasia will be able to repeat much better at a much higher quality of repetition, articulation, phrase length, everything than their spontaneous speech would suggest. Folks with transcortical motor aphasia also have very strong oral reading ability. So they may be able to read aloud much better than their spontaneous speech would suggest. So again, those are 2 differential diagnostic symptoms, repetition and reading, to help us decide between Broca's or transcortical. The third type of aphasia is global aphasia. And as it suggests, this it does suggest that a large region of the brain has been damaged, multiple sites of lesion. So the folks with global aphasia will have deficits across all modalities, not just their speech and their language abilities, and we won't have one that's stronger necessarily than the other. The damage is going to be global or across all modalities. The fourth type of aphasia is a Wernicke's aphasia, and there's another term you should recognize from the beginning of the semester. Wernicke's aphasia. The injury is to the superior anterior regions of the temporal lobe. So we've moved from the front more toward the temporal lobe, but Wernicke's area is high and toward the front of the temporal lobe, which is why we possibly also have some overlap damage in the parietal lobe. It results in a fluent receptive sensory aphasia. So fluency of speech is pretty good. These folks, the overriding symptom is comprehension. So it's why it's called a receptive aphasia. So a fluent receptive sensory aphasia. Good fluency, good melody in their speech. Utterance length is good. In fact, they can be quite verbose. And here's one of those terms, I believe, in your that chart that I said has terms in it. Logorrhea. They're verbose. Logorrhea is a term that makes me laugh because the way I remember it is it sounds very similar to diarrhea. It's diarrhea of the mouth. These folks can talk and talk and talk and talk and talk and talk and talk. Their content of what they may be talking about is very limited or is somewhat limited. In other words, they may be nonsensical, but their speech is fluent and has good length and nice melody. It just doesn't make a lot of sense. If they present with paraphasias, they will be semantic paraphasias. It's impacting content, okay? They also may use neologisms. I hate that word. I never say it right. Neologisms. It's in that chart in the text on with terms. It's the use of made up words. So they just make up words that may sound reasonable, sound like they belong in the sentence, but they're not correct words. They may also use jargon, which is the combination of real words put together without any meaning. Again, their speech is fluent, but the content is lacking or even completely empty. These folks also lack personal insight, so they are unaware of their errors. They assume that if there's difficulty with comprehending what they have to say, it's your issue, not because they're not saying things absolutely correctly. They are going to have great difficulty with comprehension in both verbal and written messages. They will have some difficulty with repetition, and they will have difficulty understanding. So, I'm sorry, I'm going to tie that to the repetition. They have difficulty with repetition because they have difficulty understanding what they've heard. So you can imagine if I say a phrase to you in a language that you don't understand and ask you to repeat it, you will have more difficulty than if I say a phrase to you in your primary language. So they have difficulty repeating because they're not retaining in working memory what they've heard in terms of being able to understand it. They have significant naming difficulties and will use both phonemic and semantic paraphasias, although semantic tends to be the most prevalent. They also will use circumlocutions. Now, we talked about that term a little bit in the chapter on stuttering as one of the kind of escape behaviors. But in this sense, it's the I cannot find the words I want. The content is missing, so I'm going to talk all around what I really want to say. Reading may be intact and like reading aloud, and writing can look very fluent. Again, they can just keep right on writing. However, the comprehension of what they read is just as adversely affected as is their content in what they are writing. So you can see comprehension is impacting overriding in that Wernicke's aphasia. The fifth type of aphasia is a transcortical sensory aphasia. This is damage at the border of the temporal and occipital lobes, so superior region of the parietal lobe. It's going to look just like Wernicke's aphasia in its symptom mix, except they have excellent repetition abilities, sometimes to the point of being echolalic, like we would think of in autism, okay? Please don't be confused. These folks do not have autism. But their ability to repeat what they've heard is very good. So you can see why that's different than Wernicke's and would be a point of differential diagnosis. Everything else, the symptoms are going to look just like a Wernicke's aphasia, but they can repeat. So that's a transcortical sensory aphasia. The sixth type of aphasia is a conduction aphasia. And this is where there's injury to the temporal parietal region. So the pathway between the speech production area and the speech reception area. These folks will be fluent with only mild to moderate difficulties with expression. Their prosody, so the melody of their speech and articulation are probably very typical, very normal. They have only slight comprehension deficits, but they will have great difficulty with repetition and great difficulty reading aloud. They can receive and process both spoken and written information, but have difficulty with verbal output, the content of the verbal output. They are very self-aware and will attempt to revise and repair communicative attempts. They have very mild to moderate word finding problems, so they don't have the number of paraphasias. They cannot read aloud, but they can read silently and understand what they've read. So it's a very odd mix within those 6 behavioral symptoms. The seventh is anomic aphasia. And this one is interesting. There's no real specific site of lesion within the brain. It's a fluent expressive aphasia that has really very few deficits except for naming, so that they present with both phonemic and semantic paraphasias. They struggle with that word finding, and it expresses itself both in speaking and in writing. They have great difficulty finding the right words. It is the most pervasive of the aphasias, and it can be considered even chronic even after there's been treatment for it. So those are the 7 types of aphasias. And I know that was a lot. What I want you to mostly know of that are Broca's and Wernicke's. They are the 2 most common types. I want you to understand those 6 behavioral symptoms and why it's important and why they are important, which ones of them are important for differential diagnosis, and that's mostly repetition and then the reading and writing abilities. But I'm not going to ask you to fill in charts with each of the different aphasias and all of their symptom mixes. But please do understand Broca's and Wernicke's. Those are the 2 most important, and then the behavioral symptoms and why those are significant. Identification and treatment of aphasia is always interdisciplinary. Both the identification and the treatment, rehabilitation. So it's always an interdisciplinary team. We are going to assess only speech and language functioning. Knowing the site of lesion from a chart and is useful information. So again, the first part of assessment will be chart review, so we can find that information. That is going to give us information about what we can expect this person to present with in terms of those 6 behavioral symptoms. Although remember, the person sitting in front of you doesn't know that information and may present slightly differently. We also need to know those premorbid factors. What we are most concerned about is that symptomology. So, in identification, we are looking for we're looking to answer 5 questions. The first question is there an aphasia present? Are we even seeing a disturbance in language? The second is what symptom mix um, is present that helps us identify which of the aphasia syndromes. So that symptom mix, along with what is the site of lesion, which we've already learned from the chart review, is going to help us identify which of the aphasia syndromes. The third question we're looking to answer is what treatment plan is going to be most beneficial for this patient. The fourth is the prognosis for recovery. And again, this is not necessarily a medical prognosis. That's not our job in this. The medical prognosis, that's up to the neurologist and that medical side of the team. But prognosis for recovery, if we look at the symptom mix and the severity of those symptoms, and we know something about this patient's overall health and overall support system, we can make some statements about prognosis for recovery based on the kind of rehabilitation we know we can provide. And then our fifth question in doing our assessment are, do we need other referrals to be made? Some of those could be medical, some of them could be psychological, some of them could be more on the side of social work. So screenings can be done at bedside very soon after a neurological incident is identified. So oftentimes this is just after the person has been maybe moved to the floor out of the emergency room when they're stable. So all of their medical conditions are stable and they have some level of obviously consciousness. They're relatively alert. So screening is going to look for things like orientation. Do they know where they are? We might ask, do you know where you are? Do you know your name? Can you tell me who's the president? And I know that seems like a really funny thing for me to say right now in the midst of, I'm recording this November 9th. So we've just in the midst of the election, but that's a really common question to ask an adult patient. Do you know who the current president is? Do you know what season it is or what month it is? So we're looking for orientation. Do they know where they are and what the events of the day are? We're looking for their responsiveness to those things. Obviously, we're going to look at their speaking ability as they respond to those questions, their listening ability, and maybe some reading and writing. This screening should not take more than 20 to 30 minutes to perform. This is a patient who is just stable, still in the hospital. So we don't want this to take a whole lot of time. More comprehensive assessment will be done after the patient is really medically stable. Most clients will experience some degree of spontaneous recovery. So that's also good information. If we've done a screening and we know what a baseline level was from that screening, and we come back in a day or two later, we can see if there's been some spontaneous recovery for language and speech. Our assessment should always be very comprehensive and should include language expression, motor output or motor ability of the speech mechanism, language comprehension, repetition, naming, reading and writing, right? All of those. So language expression being that fluency piece of the behavioral symptom mixes. We also have to look at coexisting conditions. This is part of our job. So we're looking for those dysarthrias and apraxias that may come along with damage to those language centers. Hearing must be assessed by an audiologist, and obviously we need to know the patient's prior hearing status. So we need to do things when we go into a room, like look around and see if we see hearing aids laying on a bedside table, or ask the caregiver if this patient has hearing aids or glasses that they need to be wearing. We may need to refer out for psychological assessment due to the impact of the client's condition on their mental health. If you recall, I said aphasia itself is not a psychological issue. However, I'm sure you can imagine someone who's had such traumatic neurological event may have some mental health concerns that come along with it. Sorry, I have to log back in. And I didn't do it right. Okay. So we may be referring out for a psychological assessment. So as I said, the prognostic indicators. Where is the lesion within the brain and how big is it? What is the type and severity of aphasia? What is the patient's handedness? A left-handed person with left hemisphere damage compared to a right-handed person with left hemisphere damage, some of that will play in to prognosis with rehabilitation. The patient's age. The older a patient is, the poorer the prognosis for recovery from stroke. What was their pre-injury health? So if this person was in otherwise really good health before they had a stroke, we have a better prognosis or better hope for outcome. Whereas if this is a person who has high blood pressure, diabetes, has had heart issues, or other